Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for January 13th, 2022. We've been off a little bit, a lot of vacation. We had COVID hit us pretty hard here. As I'm sure it's hit all of you, and right now we're pretty healthy, so we're going to have a conference today. We're all glad to be back. We'll be off next week. I'm out of town, and then we'll be pretty regular, hopefully, from that point on. Today's case is a case of mine, so I'll be presenting the case and doing the discussion. As usual, the case has been de-identified, the dates are changed, the ages and everything else are changed. Today's CME activity code is off the screen. There we are, 484479. This is being recorded and it'll be uploaded to YouTube by Dr. Baxi shortly. Please subscribe to our YouTube channel. If you're not on our mailing list and want to, please just send us an email and we'd be glad to add you. Subscribing to the podcast to the YouTube channel just basically sends you an email when we upload a new program, so you won't get a lot of other stuff. Everybody's being muted except the faculty. As usual, we have nothing to disclose today. We have a guest, Dr. Kaza from, I hope I'm pronouncing that right, Tiffany Kaza from Arcana. So welcome, this is exciting to have somebody from Arcana here today, and hope we're on our best behavior so she could come back, maybe get some of her colleagues to join us at times. I'll start presenting the protocol.
We've been to Arcana, Roger. I'm not sure the best behavior is a prerequisite for anybody from Arcana to come back and join.
Well, yeah, Bill and I. Go ahead.
Oh, no, thank you. I'm happy to be here. Usually it's crunch time, but I'm on vacation. Thanks.
Oh, okay. Well, I'm gonna have to write you a note so you can come every week if that'll get you off of work. The patient is a 55-year-old Black woman who came to the hospital with confusion and tremor. In the emergency room, she was found to have a BUN of 102 milligrams per deciliter and a creatinine of 16 milligrams per deciliter. She's a relatively complicated medical course over the last several months as follows. Approximately 2 months ago, prior to this, she had a total knee arthroplasty at Rush for osteoarthritis. On that admission, for that operation, her creatinine was 1.4, and she had AKI after the surgery, and her creatinine peaked at 4.4. But within 2 days, it came back to her baseline creatinine of about 1.2. Her urinalysis during that admission, again, this is 2 months ago, 2 months prior to the presentation. Her urinalysis showed 1+ protein, 2+ blood, but it was a very contaminated specimen, and a urine culture was not done. She had an uneventful recovery, but 1 month later, which is now 1 month prior to this present admission, she presented with acute respiratory infection with fever and was diagnosed with COVID. She was admitted to the ICU. She was hypoxic, requiring oxygen, but not intubation. She received Decadron and remdesivir. Her creatinine admission was 1, and it increased to 2, but it came back to 1 on discharge only 4 days later. Her urinalysis during day 2 of that admission showed only trace proteinuria and no blood, RBCs or WBCs. She now presents, this is 2 months after her knee operation, 1 month after COVID. She presents with acute renal insufficiency, confusion, and tremor. She's not had anything unusual at home over the last few weeks, except and including any new medications or non-steroidals. She's not had any fever, chills, cough, rash, swelling, blood in her urine. Her BUN and creatinine were now 102 and a creatinine of 16. The urinalysis dipstick now showed greater than 600 milligrams per deciliter with 2+ blood, 3 red blood cells, and 2 white blood cells per high power field. Her urine protein creatinine ratio was too high to calculate based on a measured random urine protein of greater than 2,000 milligrams per deciliter. She's a Jehovah's Witness and she refused consideration of a renal biopsy. A dialysis was initiated on the 3rd hospital day. She remained oliguric and finally consented to renal biopsy on the 8th hospital day. Now, only because if she would need to remain on dialysis, she wanted to know what had happened to her kidneys. Her past medical history was significant for obesity, osteoarthritis. She also had optic neuritis felt to be kind of a MS variant, diagnosed in 2019, which was originally treated with plasmapheresis. But since then, she's been receiving rituximab every 6 months, and the last dose was in 6/21. She's not diabetic, but has had hypertension for many years. She received a single COVID vaccine also around the same time of her last rituximab. She had the total knee replacement in October of 2021. She was a non-smoker, no drugs, no alcohol, nothing really over the counter. She's Jehovah's Witness and would not accept blood transfusions. There was no family history of renal disease. Her medications were amlodipine, Lovenox, and this was since her COVID diagnosis. It's a rush kind of routine prophylactic measure. And she was on gabapentin 100 milligrams BID and Protonix 40 milligrams a day. She had no allergies. She was 5'2", 204 pounds. BMI was 38. She was an obese female, a bit confused with an occasional myoclonic jerk. Her vital signs had a blood pressure of 110/60, temperature 99.4, heart rate 94, respiration rate 22, and she was in no acute distress. Her lungs were clear. Cardiac exam was really unremarkable. Abdomen was soft, 1+ edema, no rash. She had post-surgical knee, but skin was intact, no warmth or tenderness. So really she didn't look that bad, except a little bit confused and had an occasional myoclonic jerk, and her blood pressure was normal, and she was febrile. Her labs had a sodium of 138, potassium of 6, chloride of 102, bicarb of 16. Her BUN was 102, her creatinine was 16, her calcium was 7.3, albumin 1.9, LFTs were normal, CPK was 20, and her lipids were not done, I say blushingly. Her hemoglobin was 8.9. Her white count was 8,000 with the normal differential, and only 2% eosinophil, 0.2% eosinophils. And her platelet count was a little elevated at 628,000. Her urinalysis had a specific array of 1014, pH 6.5. The dipstick was greater than 600. I write that in parentheses because it's just a dipstick. It's not very valuable, but it's as high as it'll register. 2+ blood, 3+ red cells, 2 white cells, and the urine protein creatinine ratio was something we don't really know because they couldn't even measure the urine protein. This would end up being about 7, but it could have been 30 for all we know. Other tests, a 24-hour urine wasn't done. She was oliguric. Her other tests had a hepatitis B surface antigen was negative, hepatitis C antibody was negative, HIV was negative, ANA negative, ANCA, MPO, PR3L negative, complements were normal, rheumatoid factor less than 15. Serum immunofixation had no proteins. Her kappa and lambda were both elevated with a normal ratio consistent with her renal failure. And they repeated her COVID rapid antigen, which was negative. Her ultrasound had normal sized kidneys, 10 and 11.3 centimeters with increased echogenicity, but no hydronephrosis. Her hospital course was remarkable for her confusion and tremor, really resolving on stopping the gabapentin and starting dialysis. She remained oliguric, and a CT-guided percutaneous renal biopsy was done by our heroes in interventional radiology on a Jehovah's Witness with a hemoglobin of 7.3 the day of the procedure, and she tolerated it well. Are there any questions for me? Anti-GBM level was not done. That was in the, I see that in the text box.
Was there a bronch, or it was just classic ground glass opacities and COVID pneumonia too, or?
There was no bronch. All right, Bill, since you had the question, why don't you walk us through your thoughts on this case?
Yeah, sure, thanks. Pretty tough case because she seems to be on Rituxan already for this previous optic neuritis, and she had plasmapheresis. So there's a lot that could be going on because that could be masking things. But when I first look at it, what we were seeing a lot of renal diseases in COVID patients were occasionally non-COVID related renal lesions. And in this consideration, I would think about a pulmonary renal syndrome that's being sort of disguised as a COVID pneumonia, and then there's renal failure. And so we've got some hematuria, we have quite a bit of proteinuria, and I would consider the pulmonary renal syndromes. Pulmonary renal syndrome, if you're already on Rituxan, is it really going to happen? Is your ANCA going to become negative? We don't have a GBM antibody. We don't have the full lupus serology. So I'm thinking about pulmonary renal syndromes in terms of vasculitis, good pastures, lupus, and lupus nephritis. So I think all of those are possibilities. if this really isn't just a COVID-related renal lesion. And then if it's really all just COVID pneumonia and she happens to have AKI, what are those lesions that are kidney lesions associated with COVID? Well, we typically see COVAN, which is our collapsing glomerulopathy. That would fit very well here because we have significant acute kidney injury, nephritic and nephrotic, and that's a significant overlap when we see that collapsing FSGS. I think about other overlaps where you have a lot of nephritic and nephrotic. I think about MPGN syndrome, but I don't really see anything here that's pointing me towards an MPGN. Other COVID-related lesions, I think IgA nephropathy has been discussed. I think ATN, I think thrombotic microangiopathy as well, and she could have any of and all of those lesions, but I wouldn't think a TMA or ATN with this much or this aggressive proteinuria. So I think if I was going to relate it really to COVID, I'd probably pick a collapsing FSGS. If I was going to think that COVID might be the red herring in the kidney, I would think about more of a pulmonary renal syndrome. Since it's biopsy conference and I have to pick one, I'll probably go with a collapsing FSGS and call this COVAN.
Well, how do you feel about the fact that, when she had COVID, she had a normal urinalysis and went home and did fine and comes back a month later with renal failure and proteinuria?
Yeah, I mean, it's pretty tricky. Her first renal failure with the knee, she had some abnormal urine findings, and then later she didn't. She's also on Rituxan. I mean, really difficult, I think, to tell what's what there. So I think it's hard. I think this is almost like when we see a patient who has lupus and we know they've been treated with different agents and it's not a treatment naive lupus patient. It's somebody who's been on Cellcept and we're still trying to discover what they may have. So I think any of these things could be possible.
Dr. Corbett, what are your thoughts on this case?
I have a question. Did she ever have any pulmonary hemorrhage?
No.
She never had hemoptysis. Yeah,
No.
I mean, I agree with a lot of what Bill had to say. I mean, the first thing that came to my mind was this is COVID related. And it's just, I mean, I don't know why in my attempt to catch up with my reading, I thought I had run across some things where some of these patients can present later than after the acute infection. And she's only about a month out. So I think that collapsing FSGS with AKI would be a good thought, especially since she's really presenting with what sounds like florid nephrotic syndrome. I mean, she's got proteinuria that's unmeasurable. Her albumin's 1.9. Her lipids weren't done, so I assume that means they were really high. But
they actually weren't done.
Yeah, it doesn't matter. But I have to admit that was the thing that was standing out. I agree with Bill. You're trying to tie it into the original knee surgery. It would be interesting if she had an infection-related GN of some sort, but she doesn't have any of the serologic findings to go with that. It'd be interesting to know what her ApoL1 is because these patients are more at risk of AKI and potentially, I would guess, collapsing FSGS as well, but I doubt that we'll know that. But I know I'm going down the rabbit hole here, but I like this COVAN associated with a relatively recent episode of COVID. I think that fits probably as well as anything. You could go off on other tangents, but to me, that seems to be the best fit right now.
What do you think?
To try and say she has, minimal change disease kind of out of the blue and has ATN as a result that just kind of happened for whatever reason, I think is a stretch. I mean, she could have the tip lesion, all these other things, but I think just given the sequence that you've outlined here, I think COVID-associated collapsing FSGS with either interstitial nephritis or ATN would be a good thought.
Why do you think her creatinine is 10 or whatever?
16?
16. Yeah, sorry.
No, she's in big time renal failure. I think whether it's chronic or acute, we'll find out.
Well, that's a cop out. Do you think it's chronic or acute?
With collapsing FSGS, it's kind of like wildfire going through a forest. We'll have to see. My guess is she's going to have widespread lesions. And you can, and the creatinine is increased as a result of that, or it could just be as a result of ATN. And that's obviously why you did the biopsy, because she wants to know what her options are as far as potentially coming off. I don't know if you're going down the path of does she have widespread diffuse crescentic GN? I guess that's a possibility. And then the question is, why does she have it?
Yeah, I mean, the path is, you've kind of discussed the path. We certainly see patients that are this nephrotic have a much higher incidence of ATN for various reasons. And if this is, so she could just have severe nephrotic syndrome with ATN. We see that all the time, where she could actually have, like you said, this is a pretty aggressive, collapsing FSGS is a pretty aggressive lesion. I just don't know about chronic renal failure in a month. And that's what I wanted your opinion on, even though your term was, I don't know, you used a pretty good term there, but
Wildfire.
wildfire. Yeah, good. I like that. Dr. Glassick, could you put your nickel down? Do you think this is going to be?
Oh, nickel. Jesus Christ, man. Things have gotten cheap. It used to be a quarter.
Dick's of a different vintage.
Yeah, I'll put a penny's worth in.
Jesus
Yeah,
Christ.
her kidneys look a little large for a 5'2" person,
Yeah.
and they are echogenic. Large kidneys with echogenicity and massive proteinuria in a Black person who was recently recovered from COVID and was treated with rituximab, Decadron, and antivirals. I would go with collapsing FSGS. I must say, I don't think I have ever seen a patient with a creatinine of 16 due to crescentic GN who had proteinuria of this magnitude. Proteinuria is a massive proteinuria, and nephrotic syndrome is very, very exceptional in patients with crescentic GN. I don't know why she's so anemic. A hemoglobin of 7 to 8, it may just be a part of the kidney failure, but I wonder whether there isn't a component of MAHA. I don't see an LDH. Patients with COVAN do often have a component of MAHA. I would certainly like to see the smear in an LDH. I know her platelet count is elevated, but I'm still concerned about the possibility of a MAHA-related anemia.
Her LDH
I go with collapsing FSGS.
So her LDH was normal, and there were no schistocytes on the peripheral smear. You bring up an interesting point, though. The large, the kidneys being relatively large for her size. That's described in HIVAN, HIV-associated nephropathy, and I never really thought about it. There's so many similarities between HIV and COVID, and which we'll get into possibly.
Well, what about the possibility of, nephrosarca, if anybody still believes in that? I mean, could the kidneys just be enlarged because of the severe nephrosis and
That's a really good point, Steve, except she really wasn't that edematous. Which also is interesting because, when you look at, again, getting back to the HIV nephropathy, those patients, they often don't have significant edema, despite really very significant proteinuria. It's kind of often explained by their high total protein. But
and their blood pressure is normal too. It really goes along with all that same pathophysiology of either tube interstitial disease from the cystic dilatation and salt wasting, or even a high amount of polyclonal gamma globulinemia keeping things locked in. It's really looking a lot like the classic HIV nephropathy here.
And I'm glad that came out, because I thought about it barely until really Dr. Glassick brought up the large kidney size, the strong association between those two, or similarities between those two. But I don't know that anybody's ever reported that kidney size is on the large side with COVAN. It'd be interesting to look into that. Does anybody know that throw in the text box or speak up? No.
Hey, Roger?
Yeah.
If you knew this patient had 2 APOL1 risk alleles, would you still have done the kidney biopsy?
Yeah, I think so.
We needed something for the conference, for God's sakes.
It's an easy call, because I wasn't going to do it because she's Jehovah's Witness, and it really was off the table. And then she said, I really want to know, and so we asked IR, and they were happy to do it. So I wouldn't have done it, but I was happy to get the tissue. So I'm a little biased there, but she really wanted to know what's going on. She was very uncomfortable with the fact that she's going to be on dialysis the rest of her life without knowing what did this. So it's a really good question, though. I mean, it gets, more and more, we're having more and more markers, and we talk about the PLA2R with membranous, and this may come up more and more in the future. It may be something we'll do with minimal change now if our markers turn out to be as good as they possibly will be. So
Actually, you bring up an interesting point here. What is there any reason you didn't have IR pursue a transvenous biopsy as opposed to percutaneous, given her Jehovah Witness?
listen, I let IR do whatever they want to do. If they want to do a nephrectomy, they'll do a nephrectomy. And I say that, it sounds like I'm being
Jesus.
flippant here, but no, I mean, it's their call. They got to know what they feel is the safest. And I wouldn't even butt in for a second, on what they did. So I would just throw that they were, they were amenable to this with a Jehovah's Witness with a hemoglobin of 7.3. But she did fine. Then that's just the way it was. Any other comments before we take a look at this at the biopsy and spin the wheel?
One last question. Was she anuric or was she making urine?
No, she was oliguric, but she made a few hundred cc's, but she was not anuric.
All right. The only reason I bring that up is, and Dr. Glassick knows this better than I do, but my impression was if you had widespread crescentic GN, that would be one situation where you might see anuria. If you have 75 to 100% of the gloms involved with crescents, it's almost like renal cortical necrosis.
Yeah, that's a good point, Steve. But I don't know if that's ever been. I mean, that's classic for anti-GBM disease. But I don't know if does that hold for the others, Dick, or is it pretty much that anuria crescentic thing, a GBM thing?
Roger?
Yeah.
There's been a lot of action on social media saying that UP creatinine ratios are useless in acute kidney injury.
Yeah.
Because the creatinine excretion is so low that it aggravates the UPCR ratio, and that you should never rely on a UPCR for making any statement about the quantity of protein being excreted.
That's a
Do you
good
agree
point.
with that?
Well, I think it's limited. I mean, I have no problem with that. But her urine creatinine was 317. So it's not that her urine. I mean, that ratio, whatever you make of it, it's not because her urine creatinine was very low, and the urine protein was off the wall, so it was sky high. So I don't think I'd put much weight on it as a number, but I wouldn't disregard it here.
No, but that's a good point. I mean, Paul Kimmel a number of years ago, I can't remember, that was Jason, I think it was C. Jason, did a review on a bunch of these urine chemistries that in the setting of oliguric AKI are not as good as we think they are. And urine protein creatinine ratio, as Dick was saying, was one of them.
Okay, so we're going to spin the wheel. I like to point out the wheel now has 3 new names on it because our second year fellows have graduated off the wheel, and we're moving our first year fellows after their first 6 months of fellowship onto the wheel. So we now have Kelly, Melanie, and Chintav. I think Chintav's on a flight somewhere. And we'll have to see. If you remember, the wheel really, really loved Faraz. The wheel really loved Faraz initially. And then somehow it as luck would have it, it became Asim was his favorite friend. So we'll have to see with the new fellows if the wheel favors anybody. So this is the first spin of the new wheel.
So
Never
the wheel is
question the wheel.
his.
Rule number 1, never question the wheel.
Absolutely, the wheel rules. I changed my lighting for Dr. Corbett's request here, so.
It's still got a
Mel.
big time glare.
No extra pressure with Arcana also on the line. It's not that big of don't worry about it, Mel. I mean, it's just it'll be just another day in the walk in the park.
Yeah, it's just Arcana, just the biggest nephrology lab in the world. Yeah, thanks. Yeah, I just wanted to go over the whole story here. So just to reiterate, this is when she. Can we go back? Live control?
No, Melanie, just go back one screen. Yeah, I can do it. There we go.
I spent all this time making this graph and I forgot about it. This is when she had the AKI with a total knee replacement, and about a month later, this is when she presented with COVID. And here she was oliguric. This is the present admission. Dialysis was started, and then 9 days later, her biopsy was. So, I kind of went over this, but that was the story. So let's get the path here.
All right, Melanie, click on the screen. All right, now you can control the mouse and advance the slides. There you go.
There we go.
Yep, there you go.
Okay, so the first slide here at low power is a trichome stain. It looks like there's a lot of uptake. So I'd say that probably signifies that there's a lot of fibrosis here.
Yes, it's diffuse.
Yeah.
I really don't see any. I mean, it's a little bit understained. The red didn't stain as good as normal, but it looks like a diffuse fibrosis, tubular atrophy. Okay, let's go to the next slide.
David, did you put a number on that degree of fibrosis?
90%.
Okay, so we have a high power view here. Is this is a PAS stain?
Yes.
Yes. And it looks like we have one glomerulus here and maybe a remnant of another one. It does not appear normal. So there's maybe some mesangial expansion here. I don't see like a clear Bowman's capsule. So it makes me think that the parietal cells are, I guess, I don't know. It just like seems like they're kind of coming in. I'm not sure how you would describe that, Dr. Simborg.
Yeah, this is a tough lesion for your first biopsy conference. Actually, let's correspond this with the next slide. Advance it. The same glomerulus will be on the silver stain. It might help you, and then we'll come back to this.
Okay.
So Mel, Bowman's capsule is intact. I think what you were saying is Bowman's space.
That's right. Sorry, Bowman's space. Exactly.
Yeah. Now, remember what's in everybody's differential and what lesion we would expect to see.
Okay, right. So this is the silver stain, high power view of the glomerulus. Following along here, I don't see any break. I know we use the same kind of look for breaks or holes.
Does the tuft look open? The capillary loops look open, or do they look collapsed?
I'd say some of them look collapsed. Like these ones here look open, but
yeah. So if you go over to like 9 o'clock, that whole segment of tuft is collapsed.
Yeah.
And then what are the cells proliferating around it?
Those are the parietal cells.
No, so parietal epithelial cells would be a crescent. These are visceral epithelial cells, or podocytes. And then they also have protein droplets in them. If you go to like 7 o'clock, those black dots, yeah, up there, up at 12 o'clock. So this is a collapsing lesion. The glomerular tuft is imploded and the basement membranes have collapsed. So let's go back to the PAS now. No, you went forward.
Yeah. Okay.
There you go. Yeah. So that's the same lesion you're seeing there. So all those cells in the urinary space are podocytes that are proliferating, and you could see little red dots. Those are protein resorption droplets within the podocytes. But it's not necrotizing, so it's not a parietal epithelium that's proliferating.
David, sometimes do they call this like the pseudocrescent in collapsing FSGS? Is that kind of what? Because it looks like it's not a crescent, but they call it like a pseudocrescent.
Sure.
It kind of looks like it because you have that proliferation of the podocytes. It kind of fills up that Bowman space.
It doesn't really look like the crescent phase of the moon, though. But
no.
So along the lines of the question of the proteinuria in this patient, I mean, I think that I don't I can't remember seeing protein reabsorption droplets. You often see them in the tubules. I can't remember seeing as many protein reabsorption droplets in a glomerulus as we see here. So I think, whatever our protein creatinine ratio value is worth or worthless, our pathology is supporting the fact that this patient has massive proteinuria. Steve, you're going to help me out here, but isn't this what Mel Schwartz originally described as the cellular lesion?
Yeah.
That's the best you can do
Yes.
is yeah?
Well, I didn't know. You usually tell me to, not say anything. So I'm trying to, I don't know which end of it I'm on now. Yeah, he actually called it the early lesion originally. And then this was in recurrent FSGS in patients with, idiopathic, if you will. But then there was pushback on using the early lesion, and then basically called it the cellular lesion. And just to, I guess, go down that path, the reason is as opposed to collapsing FSGS, which kind of highlighted the collapse of the capillary loops, since the feeling was that this is really an epithelial cell lesion. He wanted to highlight the fact, he and Ed wanted to highlight the fact that it's the proliferation of the visceral epithelial cells that's really the issue here, not the collapsed capillaries. And so I think that was the whole purpose behind that terminology. And the fact that these cells dedifferentiated, markers of maturity like WT1 and synaptopodin became absent, and then a proliferative markers like Ki67 you would see. And actually, Vivek Dagadi and Laura Barsoni in particular talked about this whole dedifferentiation of these visceral cells. But yes, that was exactly the lesion. And there was a lot of pushback from other groups. So we kind of all just finally, after the classification came out, just accepted collapsing FSGS as the description of this lesion, which, as everybody knows, these lesions are basically just that. It doesn't tell you anything about the pathogenesis in a particular situation.
David, can I ask you a question about those droplets again? It seems like protein resorption droplets, the size of the protein droplets are usually very uniform. And as you mentioned, they're usually in the tubules. Is it possible that these are lipids? Because they look very large and they kind of coalesce and almost like the Maltese cross and very like hydrophobic, kind of attached to each other. Are these, what would a lipid globule or a glob look like on a PAS? Or would it stain at all?
Mel, could you forward one? Because I think in the Jones, Casey's point is particularly noticeable. There are wide differences.
Yeah,
in
these look
size.
like lipids.
Yeah, so the lipids, I'm thinking it's the lipoprotein glomerulopathy. And so when you stain that with the lipid stain, they're positive, but these are not positive for
No, but I think the question was, could this still be the same thing? Could it look like, do lipids look like these proteins? I know, what is it? You stain it with usually oil red O or something to.
Yeah, oil red O, that's right.
So, the question is, though, with a PAS stain, or in this case now a silver stain, would that co-stain, would that co-equalize with, or colocalize, I guess, with the lipid as well as with just a regular lipoprotein as well as albumin, I guess?
Yeah, I don't know that's ever been looked at. I mean, the textbooks, the literature all states these are protein resorption droplets. I can't give more information than that, I guess.
Dick, do you recall?
No, I don't, Steve.
Yeah, I don't.
I mean, these look like aggregated protein reabsorptive droplets in a severely dysfunctional podocyte.
Yeah, very much so. But it's a great example. It's a beautiful example of a globally collapsed lesion or glomerulus.
Normally,
Right.
these protein reabsorptive droplets undergo phagocytosis.
Yep.
And the normal autophagocytic processes of the podocyte easily can manage the protein overload. But in this case, it's so severe that I imagine that the phagolysosomes are just overwhelmingly dysfunctional.
I want to, from the chat, Dr. Kaza had mentioned that lipid is usually PAS pale, and I think that's real helpful here because they were fairly PAS positive. And she said, you know, as in lipoprotein glomerulopathy or Fabry. And she agrees that these are just protein resorption droplets. So thank you.
So
Mel, keep
Melanie,
going.
continue. Yeah.
Okay, so here we have another high power view of the glomerulus with the PAS stain. With here you have the near, like a pretty large area, focal with mesangial expansion. I don't see any open loops in this area here.
Yeah, so Maloney, you have a segmental lesion there. In our past training, you kind of have three options for a segmental lesion: a crescent, a scar, or endocapillary proliferation. So what do you think that segmental lesion would fall under?
Is it a scar?
Yeah, good. Yeah, you have a adhesion to Bowman's capsule between 1 and 3 o'clock, and yeah, it's consolidated. Yeah, good. So you have a segmental scar, and in contrast to the last one, this one is more like an NOS type. It doesn't really have collapsing features.
You know, it's an interesting point because the lesion collapsing FSGS doesn't really look like a focal segmental scar. You know, it's more of it's a different looking lesion in because it's pretty global. But here's a nice segmental scar associated with it. So it's kind of a mixture of nomenclature.
I guess the other thing that I kind of noticed on the previous PBS line and this one too is that the tubules don't look like, I feel like they've lost their brush border here. So I wonder if there's like a component of like some ATN, but I mean, I don't know.
Yeah, those that one over at 4 o'clock looks like an atrophic tubule. Yeah, those are atrophic, kind of thickened basement membranes and wrinkled. And then the tubule above it still looks like there's some ATN, that long one. Yeah, there's no brush border. That one is not scarred down yet. Yeah, so there is some ATN.
Okay, so here again, this is a PAS stain with 2, well, perhaps 3 glomeruli here, but this one here looks completely scarred down, globally sclerosed.
Yep. And then how about the one in the top left?
I mean, it doesn't look normal. It looks.
Yeah, so it's kind of.
It's not like there's no like I guess I wouldn't say that this is a scar, but some of the a lot of the loops are closed.
Yes, we call that ischemic. The tuft is kind of shrinking down. There's periglomerular fibrosis. So that one has ischemic changes, and it's on its way to being scarred over time.
So David, why isn't that one just collapsed? Is it because there's no epithelial cell proliferation?
Yeah, and the entire thing is kind of on this. It's nicely highlighted on the Jones stain. It's kind of shriveled, and yeah, there's no proliferation of epithelial cells. There's no protein droplets, and this is just what ischemic glomeruli look like. And then how about at the bottom right, Maloney?
I was gonna say this one looks normal.
Yes.
Maybe, yeah. I think that it looks normal.
Yeah, good. Open loops, mesangium's not expanded. And then the other thing I'd highlight is in the interstitium, there's some fibrosis with atrophic tubules.
Right.
Yeah. Like we saw on the trichrome stain, a lot of interstitial fibrosis.
And then are these tubular casts?
Yes, yeah. Highland cast, Tam Harsville protein.
Okay. Great. Next slide. Okay, so we have a PAS stain here, mostly highlighting the tubules. They look ischemic, like they've lost their brush border. So
Well, yeah, so I
ATM.
think you mean injured. We
Injured,
don't
yeah.
really use ischemic to describe tubules. Some are atrophy, like on the far right. They're small and shriveled. But those ones there in the middle, yeah, they've lost their brush border and the epithelium's thinned out and the epithelium sloughing into the lumen. So those are acutely injured or ATN.
Okay, so here we have a low power view. Says H&E stain.
Yeah,
I guess.
can you find the glomeruli hiding in there? Yeah, there's one. Yeah.
This is one. That's probably
Yeah.
globally.
Yeah.
Would you say that that's sclerosis, global sclerosis?
Yeah, globally sclerosed. Yeah.
Is this
And
one
yeah,
out here as well?
Yep.
This used to be one. Maybe this one down here as well.
That's a tubule there.
This is a tubule. Okay.
Yeah. Yeah. So this is just highlighting all the fibrosis and tubular atrophy. We had 17 out of 30 glomeruli. Actually, including the fluorescence, 31 of 39 or 80% globally sclerosed, like you see here.
Oh, wow.
Would you call this, David, that similar to Hyvan, that tubular cystic dilation, or this isn't enough?
No, I don't think this is enough for microcystic dilatation.
Okay. Oh, so this is the immunofluorescence, which is negative for IgG.
Yeah, and for EM, we only got a scarred glomeruli, so you could make your diagnosis now at this point if you go to the next slide.
So I guess my diagnosis would be focal segmental sclerosis, I guess, FSGS.
Yes, and did we see a particular variant of that?
The collapsing.
Yes, collapsing FSGS. And then also ATN in a background of, kind of hypertensive nephrosclerosis.
I mean, there's clearly there's clearly some ATN, but the initial slide had 90% fibrosis, and 80% of the glomeruli were gone. So that's getting back to my question of, is this AKI or is this CKD? And I think it's pretty remarkable that we don't know how much of this happened in a month, but I'll bet a lot of it happened in a month. It also probably means, we now know she had probably, one real ATN episode when she had her knee replaced and maybe a mini little renal failure when she first presented with COVID. But we do now know that ATN is not benign and it leaves you with, some CKD. And so whatever this lesion is, this collapsing FSGS, it well could be on top of, maybe she had 40% interstitial fibrosis from years of everything else she had in her ATN. But regardless, I think I was shocked to find this degree of fibrosis and pretty much an end-stage kidney, and it did answer her question. I do have some slides. Normally, I would ask if anybody has any thoughts about treating. Anybody have any thoughts about treating very quickly? Is there any treatment for this?
How about if they had less fibrosis? I mean, that's a better question. Another question, if she had maybe 50% and a little more, less chronicity, would anyone do anything further?
I think that's a no.
That's what my guess would be, but.
Can you give me control now?
Just while you're doing this, it harkens back to HIV or AIDS nephropathy. I mean, those patients, had collapsing FSGS that, devastated their kidneys within, months. Basically, they were, on dialysis, and usually within 6 months they were dead. I mean, it was, again, a very different time. It was AIDS, but these things can move fairly rapidly.
Yeah.
Can I make a comment on
Absolutely.
the diagnosis, Roger?
Absolutely.
You can make a diagnosis of collapsing glomerulopathy with a single glomerulus. Therefore, it seems irrational to me to append the nomenclature of FSGS on the collapsing glomerulopathy. And personally, I don't see the point of calling this a collapsing variant of FSGS. This is a totally distinct disease. And I believe, based on Covan and Ivan and other, that it's better to separate it from traditional FSGS, particularly now that we're looking at anti-nephrin antibodies as possibly pathogenic in FSGS. They have nothing to do so far with Covan or Ivan.
I think that's fair, and I think I think that's fair. But we have everybody wants to put lists on everything and have a nomenclature that makes sense. But I think you're right. I think that it did us a little bit of a disservice. And that's kind of what I was pointing out with the one slide with the large segmental scar, because that's not really the lesion associated with collapsing. It's a very different lesion. So I think that's a really good point. I'm gonna take over here. It's been 2 years now, but I want to remind everybody how this all started. It was in December 31st of 2019, a little over 2 years ago. The Chinese authorities alerted the WHO of these odd pneumonia cases. They had no idea what it was in Wuhan City in the Hubei province of China. It was like many other things. We had a SARS before, we had an Ebola scare, and I don't think many people thought much was going to happen from this. And certainly by March of 2019, they isolated everybody. They completely shut down the city, and they had no new coronavirus cases being reported. I don't know how legitimate this is, but it certainly wasn't what anybody was worried about. But of course, that's not what happened. What happened is that it spread, and it's a really nice video of kind of how it happened from that area of Wuhan, where if you follow went to the big cities where everything was traveling, Bangkok and Seoul and Tokyo, and it wasn't just a matter of time before this map would basically show the world. And where we are now, we're now 5.5 million deaths from this virus that started out in this town in China, in this remote area of China. So unfortunately, when you look at it now, this is Illinois. We're now on probably our fifth surge. This was the original one here, and look how small it is, even though the death rate was so terrible, and we all thought we were going to die. And I remember coming back after being on call, going back and changing in the garage and washing my clothes every night and showering before I would even see anybody in my family. And so everybody, we started wearing masks and everything got better, and we isolated and shut down restaurants and everything. And then of course, the winter comes, and these things always spike in the winter because of it's like colds and flu because the windows are closed and things spread more easily. Then we did pretty well again with a couple mini spikes. This is probably Delta virus here, I believe. And I think we thought we were over it. And then of course, Omicron came, and that's where we're at now with this very, very contagious disease. So, who would have thought back here, if you'd have told me that this, that we'd still be dealing with this and hospitals would be full 2 years later, I never would have believed it. And I'm kind of glad I didn't know, but hopefully, who knows where we're going to be and where the next year or two is going to be. But, as every peak that I've seen on this, I just think that this hopefully is going to be the last one and something's different about it. But, we don't really know. But it's kind of amazing how far we've gone. We did COVID nephropathy, maybe year one of COVID. And I kind of said we weren't going to do any more because, it became a pretty common disease, and we weren't, not everybody was biopsying. I wasn't sure there was a great reason to biopsy everybody. Because, most of our cases were severely nephrotic, and we were finding collapsing FSGS. But, Arcana put this out. They put together a collection of their cases and put out a call for anybody else. So most of these institutions here have about 2 to 4 cases, and Arcana supplied the majority of the 240 native kidney biopsies. This was done from the beginning of the pandemic to about a year later. So they had 240 native kidney biopsies. And normally I'm very critical of of papers that have almost as many authors as subjects. But I'd like to point out that there's two very important authors in this paper. So this paper gets a total pass from having extra authors. So what did they find?
Wait a second. I think I saw Kaza on that paper too. You can't circle her, and she's here. Isn't that the last? I mean, come on.
Not only
Oh
is
my
she here,
God.
she's the last author. I noticed that. Trust me, when I saw her, when I saw her on the conference today, I quickly looked it up to make sure I had it right. And we will ask her to comment at the end on something if she's still with us. I hope she is. So what did they find? Well, this is what's remarkable about this is that, I mean, look at all the different diseases they found, and they're not like getting weird cases. They're the lab that gets biopsies from all over the place. They're not just getting tough cases. They're many hospitals. They just send all their biopsies to Arcan, not just tough ones. So I think this is a good representation of a little bit of everything, and then a lot of a couple things, and a lot of collapsing glomerulopathy, and a fair amount of ATN, and a few other things spattered throughout here. But in the big picture, it was really only 26% of their total biopsies had Covan, which I think, I would have predicted to be a lot higher, that there wouldn't have been this many of everything else. And it may be that people weren't biopsying Covan as much because they assumed it was that, and they only biopsied people that had something funny, which you could see how these would all have something funny clinically. It would lead you to the biopsy. So it may be a little biased. Regardless, they went and compared it then to their, HIV patients that had HIV that were biopsied, and you find that it's very similar. About 20% in whether they had HIV or COVID virus had collapsing glomerulopathy, and a certain relative close percent had ATN as well. So I thought that was pretty interesting. Then they compared it to their database of 63,575 biopsies. And the point here is that in their large database, Covan is collapsing glomerulopathy only represents about 2%. So it's a relatively rare glomerulopathy, except with the advent of COVID infection. So it looks like HIV nephropathy, but certainly a lot more people are being diagnosed with COVID than HIV. And this is a nice little pie graph that they showed. And basically, it shows what I just described, that if most of these are the same, except that collapsing glomerulopathy went from, a very rare diagnosis in their database of 63,000 pre-COVID to now for the COVID biopsies representing, about a third or a fourth of the biopsies here. So it's pretty interesting. They still have other diagnosis. IgA went a little bit more here, but most of the rest of them are pretty much the same. ATN looks about the same. So COVID is really has become a big problem in the renal pathology industry. So what about the APOL1? That was alluded to both in discussion. Steve brought it up and in the chat room. So what they did is they went and looked at the APOL1 genome. They didn't have blood of these patients, but in the kidney biopsies where residual tissue was available, they had 48 of them. They went and looked to see of the patients who had collapsing glomerulopathy, what percent had a high risk APOL1 allele. So the low risks are GOGO, G1GO, or G2GO, and the high risk is having either both ones, or a mixture of 1 and 2, or both 2s. And 92% of them were high risk alleles. So that clearly demonstrates that this is a very high risk, that APOL1 is a very high risk factor for Covans as it is for HIVAN. What was also interesting, they found that foot process effacement was up to 90% in the patients with the 2 high risk alleles. But if you didn't have 2 high risk alleles, your foot process effacement was only about 35%. No big surprise, but it's kind of a nice twist on the whole podocyte injury and a lesion that we see. Again, I want to stress, as we often do, that collapsing glomerulopathy is a pattern of injury. It's not a diagnosis. These are really beautiful pictures, by the way, of 3 very collapsed with a lot of extra glomerular cellular proliferation going on that aren't crescents. And they break it down into 5 different categories: genetic variants, infections. We've seen HIV, and now COVID. I've seen parvovirus, but all these have been described, as well as some, other infections, medications. pomidronate, interferon, and I've seen it in Still's disease. But the list is very long, and so you have to be careful when you see this. Like many lesions, it's a pattern of injury, and then you got to go back and find the diagnosis. Well, I think it's pretty clear here, but we end up with a idiopathic collapsing FSGS. It's good to know that there's a lot of things out there that can lead to this, and basically it's thought to be a severe podocyte injury, and from any of a number of insults that leads to this lesion, which is, obviously these glomeruli aren't filtering. You can see why the prognosis is so poor. They also reported in this, that a couple in their discussion section, a couple of the reports had seen coronavirus particles in the cytoplasm of podocytes. That's kind of similar to what was described in HIV, also having this lesion. And both have this APOL1 high-risk genotype risk factors, as I mentioned. And whether or not this is true, we'll get into, but podocytes do express membrane-bound ACE2, which is a SARS-CoV virus receptor. So it would kind of make sense somehow to how it would affect the podocyte. But whether or not the virus is actually there isn't clear. Two other reports failed to demonstrate viral DNA in the kidney, and no viral inclusions were seen on EM. And so they alternately proposed maybe a different mechanism as a consequence of cytokine release syndrome, which, we see in these patients. I got to tell you, our patient wasn't that sick. She didn't really have that kind of cytokine storm that we see, but that doesn't mean it wasn't present. But viruses will stimulate interferon, and that upregulates the expression of the high-risk APOL1 genotypes in glomerular epithelial cells. So it's kind of thought to be, like a two-hit. You're born with the APOL1 risk factor, and then the virus stimulates the interferon and leads to this. And I think that's probably what's going on here if I had to put my nickel or my quarter down, as Steve would prefer it to be, from inflation. And then this is a really nice paper, because what this case is interesting to me is like, what happens to these patients? Is she unusual? I hadn't seen anybody do this poorly, go into renal failure this quickly. So this is out of Columbia with Vivek Gotti and Glenn Markowitz, and they had 23 patients with COVAN. The median age was 59, 91, not surprisingly, were Black, because that's where the APOL1 genotypes predominantly reside, and 22 presented with AKI. At a median follow-up about half a year, 86 were still alive, and 2/3 were dialysis-free. But only a third went in a partial remission, a third had no remission, and a third either were dead or on dialysis. And I think from the standpoint of this case, 14 required dialysis, but only 7 recovered. So I don't think she's really that unusual when you look at this. She's a little, as far as not recovering. But they were very specific about not being able to see any virus in the kidney. So I don't know that is, I think that was a fluke in the earlier presentations. And this basically shows the same. This is very complicated, but these are their patients that they had. You can see that this is, they had variable levels of proteinuria, some of which were very high, fairly low albumin levels. Most of, some of them had edema, but not a lot of them had edema, kind of getting back to our earlier discussion. And a whole host of treatments. A lot of them received prednisone, but it didn't seem to help. In fact, if you look at prednisone, a lot of them died. That might have been that was the sickest patients got prednisone. It wasn't the prednisone that killed them, of course. But see the partial remission, the no remission, and the end-stage renal disease. So, it obviously is a very, very bad lesion. And this is really what happened. This is the final graph, and each of these is her dialysis, and she went home on dialysis. She never recovered. She's still on dialysis, and I'm not surprised given her biopsy finding. And I want to end it with with a question, and see if anybody has any feelings, and specifically Dr. Kaza about this. So I tweeted this out about a week ago. I said, anyone know if COVAN is less likely with the Omicron variant? And the reason I did this is because at least COVAN appears to be less pulmonary toxic, and the patients are less sick. But these aren't patients that aren't necessary. These are patients that they're not always our ICU sickest pulmonary patients that we're getting COVAN. And so I tweeted this out, and I got 9 likes, two retweets, 2 comments, which are totally worthless. But my point of this is that 5,600 people saw the question, and I got no answer, which means there probably is no answer to this. But I thought it was an interesting question. So I'd like to ask Tiffany if she has any thoughts on this, either anecdotally or otherwise. Are they seeing, since they're they're getting more biopsies than anybody probably in the world, have you noticed any less COVAN coming in?
Yeah, I looked into this, and I think I was one of the 2 useless combatants. But we checked our biopsy
Well, that's
database
awkward.
from. No, it's okay. We checked our biopsy database in the month of December, and then comparing to the month of September, when you're kind of end of, Delta versus now. Not that Delta's ended, but you know what I mean. And we had fewer collapsing cases in December than we did in September, but we have a lot more COVID now than we did in September. So I think this could be a true observation. I think we need more data, as that was anecdotal of like 30 some case or 40 some cases versus 30 some cases. But if you're looking at like 3 times the COVID numbers, it certainly could be less.
Yeah, I think that's a good point. And it may be too, though, that people are biopsying less. I remember about a year ago, I put out a tweet. I said, if you had somebody with proteinuria and COVID, would you do a biopsy? And I thought most people would say no. And 2/3 of them, of the poll, and it was another big poll. I mean, that was, a lot of people answer these, and 2/3 said, yeah, they would still biopsy. And it's kind of supported in a lot of ways by all the different lesions that you guys found. It isn't automatically going to be COVID. Now, maybe that doesn't. It's different if you look at somebody who has 20 grams of proteinuria, but it may be that they're biopsying less, or it may be that it's less, and I don't know how we're going to know, but
We haven't seen lower biopsy numbers, at least. That I don't know
that's
on
a
your
good
end if
point.
elective procedures are down, but they haven't been lately.
Well, I think that's useful information. I mean, we all hope that this, we're all praying that that Omicron is less toxic in every way. It certainly seems to be less lethal for the lungs and everything else. And it would be nice if we have less renal failure, because this is a very bad lesion, as you can see in her. This woman comes in with a creatinine of 1, and a month later she's on dialysis, and it's not going to get any better. I'd like to open up to anybody else have any comments?
Yeah, I have a question which relates to what Dr. Suki posted, which I hope the pathologist can answer. And it pertains to the fact that we say that the cells that fill Bowman space in this lesion are podocytes, are proliferating podocytes. However, Dr. Suki rightfully made the point that podocytes are not known to proliferate. So what's the deal? And I wonder if the pathologist can comment on that.
Would that be me, or do you have?
No,
Yeah,
that
I could defer that to Dr. Kaza or Dr. Corbett. I don't know the answer to that.
I thought I brought this up earlier on about Laura Barsoni looking at this and describing it in patients with what was felt to be, I guess, primary or idiopathic FSGS, where the cells dedifferentiate is kind of the term I think she used. And the usual markers that you would see, like WT1 and synaptopodin, which are markers, I think, of maturity, go away. And then you see more proliferative markers like Ki67. But I'll defer to Tiffany to elaborate.
I'm sure you have a lot more experience than me, but I agree. Podocytes are terminally differentiated cells, but it does have more of a dedifferentiated phenotype. But also, compared to FSGS, where you have loss of podocytes collapsing, you have podocyte hyperplasia, but later on, you're like other forms of FSGS have fewer podocytes and podocyturia. But
I mean, you see the same lesion in recurrent FSGS. Patients that have it, I mean, that's kind of one of the best examples of kind of the evolution, I guess, of what we would otherwise call idiopathic, where the first thing you see basically as they have this massive proteinuria are actually relatively normal glomeruli with just diffuse effacement of the foot processes. And then as you follow them out, they'll actually start to get segmental collapse, and then it evolves on into a scar. And again, for those that look at the markers, not that we ever did specifically, I kind of defer to Laura's work, but they were kind of attributing it to this so-called dedifferentiation, if you will. For whatever reason that happens, whether it's something about the permeability factor or in this case, a virus.
Great, thanks for the question, Mario. I think we should wrap it up. We're an hour and 10 minutes into this. Appreciate everybody coming. Tiffany, thanks for being here. You know, I saw a drum set behind there. You want to end us with a little drum solo?
No, thanks. Thanks for having me.
Okay. We'll be off next week. We'll come back in 2 weeks. Thanks everybody for coming, and stay safe in the meantime.